Good morning or good afternoon, everybody. Hope y'all are doing well. We have a pair of really interesting topics that we're going to cover today. Really important ones in medical sociology, that of the disability or the sociology of disability and the sociology of mental illness. So we're going to talk about both of these things at length. But first, just a reminder about an assignment we have upcoming, which is our second paper. So the second paper is due Sunday, April 6th by the end of the day. And you can find the description in your syllabus, in the updated syllabus on the Moodle page, as well as at the bottom of the Moodle page, the assignment description. So this is an ethical analysis of a contemporary healthcare issue. So you are going to critically analyze a contemporary healthcare issue from an ethical standpoint. So you're going to apply the four principles of biomedical ethics, which we'll talk about in actually future classes more, but I've described them here as your framework. So autonomy, beneficence, non-maleficence, and justice. So you're going to identify these ethical challenges inherent to the issue that you choose and evaluate its impact on different groups and stakeholders. And you're going to conclude with recommendations that align the issue with ethical healthcare standards. So you can see the four principles of biomedical ethics there below explained, 1 through 4, such as respecting a patient's right to make their own informed decisions about their care, right? That's autonomy. Beneficence, acting in the best interest of the patients by promoting their well-being and taking positive steps to improve their health. Non-maleficence, that's essentially just do no harm. Justice, ensuring fairness in the distribution of healthcare resources and treatments and access while considering those legal implications. So those are your four principles of biomedical ethics that you're going to use for this paper. And so you see the structure that I've outlined for you too. So again, you can try to align with the structure, but I'm giving you flexibility as well. So an introduction, add some background and sociological context to your topic. Then add that ethical analysis as the big bulk of your paper, talking about each of those four principles of biomedical ethics. And so that's going to be your ethical analysis. So that's that key point here of this paper. And again, I've described here some example questions of what should you sort of be asking around these key areas. So like around autonomy, how does this issue affect the autonomy of individuals or groups? What are the potential benefits for those affected? What are the potential harms or risks, or who is most vulnerable? And how are the resources, rights, and opportunities distributed across different groups? And I would maybe subheading these if that helps you as well, just sorting the paper itself. So analyze any conflicts there and analyze those principles. And then a discussion or recommendation. Again, summarize the ethical challenges that you've identified, propose potential interventions and policy changes. And you can see also the instructions, 7 to 10 pages. I put APA style. Anything APA or ASA is fine. Times New Roman or something similar in terms of font, and at least 7 academic. That's peer-reviewed journals and sources, books, anything like that. And then the evaluation criteria are also present. So again, the 4 principles of biomedical ethics. You're analyzing ethically a contemporary healthcare issue. Please let me know of any questions you have about this paper. But I'm really looking forward to seeing each of your papers, because this is a really fascinating prompt, and I'm sure you'll have some fascinating topics. And speaking of fascinating topics, let's get into sociology of disability and mental illness. But first, I want to just remind people about the sick role and medicalization, because these things will come into play during this discussion. So if you remember, the sick role is a sociological concept we have talked about a few times, and it was developed by Talcott Parsons, and it describes the sick role describes the set of rights and obligations a person has when they're sick, or essentially allowing them temporary exemption, right? Remember, from normal social roles and social responsibilities while they seek medical help to get well, right? It's that idea that you're excluded from your traditional social responsibilities with the understanding that you're working towards recovery. Medicalization refers to the process of defining a social problem or a behavior as a medical issue, often leading to increased medical intervention and treatment for that issue, with both the positives and negatives, right? That we are able to treat more things more effectively, but also that we over-medicalize and over-prescribe and that sort of thing. So be thinking about both of these as they will come up during the discussion. Just as starting with the introduction to sociology of mental health and disability. So what I want you really to understand throughout the readings and throughout this day, the sociological perspectives on these things, including historical shifts. And so thinking about social structures, perceptions, and policies that affect those with mental illness and disabilities. And then I want you to be able to analyze how medical and sociological approaches really do shape treatment and social and societal inclusion as well as exclusion. And then we're going to explore the social construction of like the sick role, right? Of the social construction of what is sick or disabled roles and the implications for policy and healthcare practice. So just to frame a couple of key concepts here, and I want to just first start with the sociological approach to these things, to mental illness and disability. So sociology in this area focuses on how mental illness and how disability are socially constructed in many ways and influenced by cultural, economic, and policy factors rather than only focusing on individual type of pathology. So some concept definitions here that are important to understand going forward. What do we refer to by mental illness? Well, mental illness is defined as a condition affecting mood or thinking and behavior that significantly impacts our daily functioning. And where disability are these socially constructed limitations that impact individuals' activities stemming from a combination of physical and mental conditions and as well as societal barriers. So important to understand each of these things. Again, we're not saying that as sociologists, we don't say that, well, the biological maybe issues or the biological struggles are not present. They absolutely are, and they're key concepts and key to understand. We're also saying there is a social element to each of these that are really, really important to understand, especially as how we treat and support individuals with disabilities and mental health needs. So be thinking about what shapes even society's view on mental illness and disability, and how might these views, impact individuals who experience them. So let's start diving in a bit deeper starting with the sociology of mental illness. So first, let's start with those historical and sociological perspectives on mental illness. So this really comes from the Scull reading, the sociological study of mental illness is what it's called. And really just the key takeaways here that I want you to get is that Scull provides a nice historical overview of how mental illness has been treated and has been viewed from moral judgment in more pre-modern society. Remember we talked way back about the history of medicine. This goes right into that. So talking about in these more pre-modern societies, pre-modern to before medicalization in contemporary society, that mental illness has historically been treated and viewed for more moral judgment. And there's been key shifts in these treatment models, right? Like institutionalization or asylums, deinstitutionalization, all of that. We moved largely away from the institutionalized approach and asylum approach. And these changes, these shifts reflect societal values around what we consider normal, right? What is normalcy? What is deviance in society, for example? Because there's an element of, historically, when we have institutionalized people with mental illness or disabilities, a bit of an othering, obviously, but almost a punishment factor as well, a shame factor. But this growth towards normalcy, ebbs and flows, absolutely. But an overall historical trajectory of bettering treatment, of treating people as people and not othering and excluding them from society. So we've seen a large shift, right? Think about mental illness in much, much older societies being even looked at through religious lens, right? Of is this person possessed, right? With people with epilepsy or schizophrenia, for example. But now we treat these individuals. It became increasingly medicalized, but then also institutionalized. Now we're moving away. We have moved away from that format. There are still issues with it that you can find all over. But it's important to understand this shift that has occurred. So think about the transition from moral blame to a more medical approach around mental illness. And how do you think this shift maybe has changed, or reflects as a change of society's approach to mental illnesses and folks actually diagnosed with it? And there's also the medicalization and the sick role, like I mentioned earlier, that plays a key role in understanding this phenomenon. So in the Barkin reading, the chapter introduces mental illness as a socially constructed phenomenon. So really discussing how the sick role and how individuals with mental illness may be stigmatized or labeled in society, right? That stigmatization and labeling is a really key component to understanding why is there still that othering component that exists in mental illness, and why does that persist? Potentially because of those historical roots that I've just mentioned. And so a couple of key takeaways from that Barkin reading here is because Barkin's discussing how the sick role influences mental illness treatment and stigma. And so the concept of labeling theory really can help you understand how diagnoses can actually reinforce societal expectations and create self-fulfilling prophecies. So the labeling theory is talking about that when you're labeled with a certain role or a certain status, like having a mental illness, that labeling theory does two things. Socially, others see you as that label, but also you tend to see yourself as that label. So it's, again, self-fulfilling prophecies as well as societal expectations. So think about that in the context of mental illness. And I want to highlight that this sick role theory, we've talked about this, but proposes that illnesses really exempts individuals from those normal social roles, but also pressures people into seeking recovery, right? That's a key part of the sick role. And that impacts perceptions on those with chronic mental illness. So think about chronic depression or chronic anxiety, things like that that are widely normalized. But what the sick role means in these contexts, well, does that mean that you're now excluded from other social roles, and how that can be a self-fulfilling prophecy? So there are issues with the sick role as a concept, as a use in society when we think of mental illness, especially. And there's also going to be a social exclusion and isolation piece because of that. And then what does recovery look like in terms of mental illness compared to more maybe curable physiological illnesses? There's quite a large difference there, right? Chronic mental illnesses emerge and are treated differently, and we are impacted by those things differently. So it's important to understand this dynamic, and that it is a different approach even socially. So some key concepts in the sociology of mental illness that we should go through. So there are 5 key concepts up there listed. We're going to go over them in the following slides in actually more detail. But first, the sociology of mental illness, just overall, explores how mental health issues, again, are not merely individual experiences, but are deeply embedded in and shaped by social, cultural, and structural factors. So think about how we need to understand how society defines and responds to and manages mental illness. And I want to emphasize that this role of social context is so critical in influencing both the experience of mental health conditions and the societal responses to those impacted by mental health conditions. How does society respond to folks with mental health needs, and what is the experience of those with those mental health needs? So let's talk about the key concepts here of the sociology of mental illness. So number 1, social construction and mental illness. So again, definition of mental illness. Sociology considers mental illness to be a socially constructed concept. And that means that what society labels as mental illness is actually strongly influenced by our cultural beliefs, by historical context and social norms. That what we label as what is a mental illness, what is not a mental illness, is so dependent upon our culture, upon our specific cultural backgrounds. And that labeling and stigma piece is important here as well. So I just mentioned labeling theory, but again, introduced by Erving Goffman, and in suggesting that individuals diagnosed with mental illness often face stigma and discrimination when they are. And labels like depression or schizophrenia or anxiety, these types of labels can lead to societal judgment, which affect individuals' self-perception and their social interactions. So again, labeling theory is looking at a two-way street, essentially, that when you're labeled with these sorts of things, it can affect your social interactions with others, how others interact with you, but also how you see yourself, your self-perception. So that labeling component is really, really critical to understand. So understanding that component, that labeling through the concept of mental illness, paired with that, what society defined as mental illness is largely socially constructed and differs society to society. Number 2, historical shifts in treatment and perception. So moral judgments to medicalization. Historically, behaviors considered as deviant, for example, were often attributed to moral or spiritual failings. So over time, society has transitioned to viewing these behaviors as medical issues, a process, what do we call that? medicalization, right? So this shift means that conditions like depression, for example, are now understood as health issues, not moral or spiritual failings. And these health issues require medical intervention rather than personal or moral failings. So there's also a deinstitutionalization piece as well. So around in the mid 20th century, many Western societies like the United States started to move from institutionalizing individuals with mental illness in, say, like, for example, like asylums, to treating them within the community much more. And so while this reduced confinement, it also raised issues around inadequate support and resources for individuals outside of institutional care. Our traditional medical format, we often we have a lot of social work students, right? Especially at Concordia. And it's important to understand that these supports, while the move away from asylums is critical, necessary, and needs to be done, there's also still a gap in who needs supports and who's actually getting those supports in community, because we have different nonprofits and community organizations that are providing that care in addition to our traditional medical institutions. So there's a lot of important nuances here to understand around the deinstitutionalization piece around mental illness, and especially as we'll get into in disability. Number 3, social determinants of mental health. So there's an impact on socioeconomic, an impact of socioeconomic factors here, as there are in so many of the other topics that we've talked about in this class. So economic inequality and unemployment and poverty and other structural inequalities, like we've talked about, play a significant role in mental health outcomes. So, for example, financial instability increases quite often stress and contributes to depression and anxiety in many individuals. So there's a key socioeconomic connection to mental health. And then race, gender, and cultural influences. So us as sociologists, we have studied this, and these studies show that marginalized groups often face higher rates of mental illness, such as in United States society, due to systemic stressors like those things, like discrimination, limited access to resources, and a lack of culturally competent mental health services. So really important to understand that socioeconomic factors, as well as race, gender, and other cultural factors, influence strongly folks' experience with mental health and the pervasiveness of mental health challenges. The sick role and the role of medical institutions. I've already mentioned it, but again, I want to keep reemphasizing how important it is to understand the sick role. So again, this concept of the sick role suggests that being ill exempts certain individuals from normal social responsibilities, but it also implies that they should seek help to return to quote unquote normalcy. So, however, again, I kind of mentioned this, for chronic mental illness, this role can perpetuate dependency and stigma, as people may be viewed as not fulfilling societal expectations for recovery. So that sick role, again, is if we're expected to recover from our illnesses, when we have chronic mental health illnesses, it's not as if you take a pill or you get a surgery and it's fixed. So that type of recovery process, that ongoing recovery process, a lot of the same things could be said for a role of addiction, right? That type of expectations to return to quote unquote normalcy, that can contribute to dependency and more social isolation as a result of the sick role. There's also the role of psychiatry and pharmaceuticals as well. So the medical field, particularly psychiatry, it really heavily influences societal responses to mental illness and what we deem as mental illness, often emphasizing medication and therapy, again, contributing to that medicalization component here. And so sociologists here examine how reliance on psychiatric diagnoses and pharmaceuticals have really shaped the perception and treatment of mental health, and really often focusing on individual pathology rather than broader social issues. So again, having to understand that sociologists coming in to a traditionally psychological dominated field, to understand we need to look at this historical and social context of all these things as well. Policy implications and social support. So social support systems are really important here, because studies emphasize the importance of this type of social support in mental health outcomes, like strong family ties, supportive communities, access to mental health resources. All these things can provide more resilience against stress and mental illness, right? We've talked about resilience quite a lot in this class. And so that type of social support is really critical. And we've talked even in other sessions about why social support is so critical to overall health outcomes. And there's also then, let's talk about policy and access to care. So sociologists, we're looking at how public policies affect access to mental health services. And we need to consider things like how insurance coverage and economic support and healthcare laws actually impact the treatment and social integration of individuals with mental health conditions. So again, take that broader perspective as we think about policy, as we think about how do we improve the healthcare system, access to care, care itself, culturally competent care, especially in mental health services. We need to think broader. We need to think about all the things we've talked about, these downstream versus upstream approaches to this field. We need to consider all of those things from a medical sociology perspective. And so just considering a couple of sociological perspectives on mental illness. So again, thinking of theories. Remember, we talked a little bit about sociological theories, and if you've taken an intro to sociology class, you'll have heard of these. But let's talk first about symbolic interactionism. So here, through this theoretical lens, we're examining how individuals' interactions and societal labels really shape our experiences with mental illness. So really, this theory is emphasizing the impact of stigma and how social interactions can either support or even hinder an individual's mental health. Structural functionism, though. This theory views mental illness in terms of social stability and social disruption and the dynamics there. So really, it's viewing that mental illness is seen as a quote unquote dysfunction that disrupts types of social harmony. And so this perspective examines the role of mental health institutions in maintaining social order. And really thinking about the concept that when something disrupts traditional social stability, you want to get rid of that thing. So that's where like institutionalization and the asylum process really comes into play. And that social exclusion that persists to this day also comes into play. Conflict theory. So this theory focuses on the role of power and inequality, really suggesting that mental health issues can arise or be exacerbated by socioeconomic disparities. And it critiques the medicalization of mental health and explores how economic and social policies can actually marginalize vulnerable populations. So really, just to summarize, the sociology of mental, because we're going to shift into the sociology of disability here, but the sociology of mental illness highlights that mental health is not only a medical issue, but it's also a deeply social one. And so mental illness is shaped by cultural definitions of what mental illness is. It's shaped by the historical context, like we've chatted a little bit about, as well as structural factors. And so sociological perspectives really urge for a more holistic understanding of mental illness, one that includes social support and community integration and greater policy reform as key to improving mental health outcomes. We have to look at all those things. We have to look at structure. We have to look at societal and social and historical context and the structures around mental health to better and improve policy in this area. So I'll be curious if you incorporate any of these theoretical concepts in your discussion prompt for the week. But we have another component as well, not just mental illness, but let's talk about the sociology of disability. So again, just a reminder about the sick role and medicalization. That it's important to understand these concepts as we're thinking about disability in society. So the Higgins, Porter, and O'Halloran reading, I believe it was a 2014 reading, talks about these things. And the study explores how general practitioners, our medical professionals, tend to manage patients in long-term sick roles, often seeing disability as a medical condition to be treated and to be managed. And so the reading underscores how the sick role affects long-term patients with disabilities, often leading to exclusion from normal, quote unquote, normal roles. So really the idea here is that viewing disability purely through a medical lens can inadvertently sustain dependency and limit one's individual agency and reinforce societal barriers. We have to understand that disability is more nuanced than you should take a pill or have a surgery and fix something. Quote unquote, what is to fix something? Is something needing to be fixed, right? There are all these really interesting conversations. So we have to consider what alternatives to the sick role might look like in terms of policy and social support for individuals with long-term disabilities, because we cannot just treat folks as, well, you need to recover. Our expectations that you need to recover from a chronic disability, when that's either one, impossible, or two, not desired by the individual. And the second component there, social barriers and disability stigmatization, really comes from the French reading, the 2017 reading. And the key takeaways here is that the article highlights the lived experiences of individuals with disabilities, and really touching on structural and systemic challenges like employment discrimination, accessibility issues, and social exclusion. And so I want to emphasize that this difference between the medical model and the social model to these things. So the medical model looks at disability as an individual's quote, problem, right? And a problem to be fixed. Whereas the social model looks at disability as a social issue, looking at disability as, well, think about the impacts of how we view disability in terms of social isolation, social exclusion, or integration. So we have to understand how these societal barriers, rather than individual conditions that we experience, actually impact the daily lives of people living with disabilities and what that looks like. And when we understand that, then we can better implement care and policies that promote community and social integration. And so the economic and social pressures also important to hit on too. And this comes from the McCoy reading. And so key takeaways here is that the article is investigating the really complex socioeconomic factors that drive people to apply for things like disability benefits, right? Such as out of financial desperation rather than more medical necessity. So it illustrates the economic inequality that intersects with perceptions of disability. There are certain laws around disability that are really problematic. So for example, I don't know the exact numbers around it. It does differ state by state, but there are laws where, let's say if you're receiving medical assistance, you're on a waiver, for example, because you are living with a disability, and this waiver helps you to pay for your rent and food and that sort of thing, and pays for your care. If you get a job, let's say, promoting social inclusion, right? Of you're getting a job, you're building relationships in that job, and you start making too much money. If you reach a certain threshold, the government will stop paying those benefits. And so it's almost like as if our policies are making folks choose. Do you want to have a job, or do you want to get support from the government, financial support, as well as even how much a person with a disability on certain waivers can actually have, how much money they can have to their name. I have a sibling living with a disability. And this individual can only have up to like $2,000 or $3,000 in their saving account before they're impacted. Their government funding is impacted for their disability and support there. So there's really interesting economic inequality here that intersects with how we perceive and support disability in society. So I want to make sure you understand how disability benefits can sometimes be more of a last resort for individuals in like economic distress, for example, because it is a cycle that folks maybe don't want to fall into. And so this raises questions about the boundaries between disability and social support. So it's really important to understand these nuances, because when we better understand these nuances around disability, then we can better address the fundamental issues that, in terms of a social standpoint, right? That we need to promote greater social integration. So you see some key concepts in the sociology of disability. There's 6 of them up there listed. We're going to get into those on the following slides. But first, just again, kind of overview and recap that the sociology of disability examines how society defines, perceives, and interacts with individuals with disabilities. It really emphasizes that disability is not merely a physical or medical condition, while it often is, but it's also shaped by social, cultural, and structural forces. So this perspective shift, really it shifts the focus from individual impairment, an idea of an individual problem, to the ways in which social environments and norms create barriers and discrimination and stigma that affect the lives of people with disabilities. Even looking at how we label things, right? What is labeled as disabled or not. That's actually language that folks are getting away from. So starting with the social construction of disability. So medical versus social model. So the medical model of disability views disability as an individual problem stemming from physical or mental impairments that need quote unquote fixing, right? A quote unquote disabled person that needs fixing. In contrast, though, the social model sees disability as a result of societal barriers and prejudices and a lack of accessibility rather than just a person's physical or mental problem. Looking beyond that, looking at, well, yes, okay, this is a situation that this person finds himself. Maybe there are certain areas that could be treated. There are certain ways in which medically we can support this individual, but how socially can we make sure that we support these individuals better? And then disability as a social category. So sociologists argue that society defines what is considered a quote unquote normal body and mind, and that these standards really marginalize those who do not fit into those cultural standards. So for example, the lack of a wheelchair accessible spaces does not inherently stem from a person's inability to walk, right? But more from the society's failure to accommodate these diverse needs. So when you think about why is it important to have accommodations in society, it's about social spaces and who is able to get to where and how we're able to interact with everyone in society equal, and how everyone in society is equally able to access our community spaces and resources. So again, thinking of disability as a defined social category that gets into that socially constructed nature of mental illness and disability. Number two, stigma, stereotypes, and social attitudes. So stigma and marginalization. So individuals with disabilities oftentimes face stigma, which can result from exclusion or discrimination and a lack of access to resources and opportunities. So this concept of stigma, really thinking back to Erving Goffman, the sociologist there, this concept of stigma is really relevant here, that disabilities are often seen as quote unquote deviations from societal norms, and then disabled individuals may be stigmatized, resulting from social disadvantages, right? Similar to how we talked about institutionalization and the quote deviations from social order with mental illness, the same thing, and even historically the same thing can be applied to disability. The historical asylum and institutionalization approach to disability that we moved away from still has its long-lasting impacts. And then stereotypes. So people with disabilities are frequently stereotyped in ways that diminish their autonomy, diminish their potential. And really, these folks may be viewed as quote unquote inspiration for simply living their lives, or pitied as victims, or having burdens put upon them. Now, these stereotypes really reinforce the concept of ableism, if you've heard that term before. Ableism really is just the assumption that able-bodied people are the norm, for example. Now, it's important to understand that ableism is really detriment in society, right? Because if we're just viewing people as either inspirational or as down on their luck, we have to view individuals with disabilities in the same way we view non-disabled individuals, just as normal individuals, right? That's the goal, right? Seeing beyond these things. So when we talk about the sociology of disability, we need to get beyond these stereotypes to think more holistically about the individual and looking beyond the label of disability, for example. Number three, the experience of the sick role and disabled role. So there's limitations with the sick role, and we've been talking about it throughout this entire session. But the sick role, again, suggests that people with illnesses or impairment may be exempted from those typical social roles, but are expected to seek treatment and recover, right? That's an overall overview of the sick role. But for people with disabilities, this can be really problematic, as it implies that they should strive towards an unrealistic, potentially, ideal of normalcy, of what is normal, even if they have a lifelong condition or one that they are okay with, or one that they're used to and comfortable with. And so the disabled role and expectation goes a little bit different. So the disabled role reflects societal expectations that people with disabilities may or may not be able to contribute to society in quote unquote productive ways, whatever that is deemed by culture and society. And this often leads to these individuals being undervalued at work, undervalued in education, undervalued in community life. And this role, this disabled role that society has labeled these individuals, can really limit opportunities and reduce individual agency. It's really just talking about how the sick role doesn't necessarily always apply to folks with disabilities, and how that can be problematic. And looking at another problematic element is that the disabled role in society and what actually goes into that. What are the long-term implications? 4, intersectionality and disability. So multiple identities and disadvantages. That disability often intersects with other social identities, right? Such as race, gender, and class, all of which can amplify discrimination and disadvantage. So for example, women with disabilities may face both gender bias and ableism, like we talked about, while individuals from marginalized racial backgrounds may experience and encounter the other things we've talked about, right? Like compounded systematic barriers in addition to ableism impact. So important to understand that intersectionality component. And then the social and economic inequality as well, that people with disabilities face higher levels of poverty, face higher levels and more limited employment opportunities and lack of access to education, all these things at greater degrees. And so structural inequalities like these things, like even inaccessible public transportation and inadequate health care, all these things further create further disadvantages and limit opportunities, including some of those policy issues like that I mentioned before, right? That on the economic side of things. Number 5, policy, accessibility, and rights. So let's talk about advocacy and legislation. So policies like the Americans with Disabilities Act in the United States aim to address discrimination and ensure equal access to public spaces, education, and employment. However, sociologists critique really the limitation of disability support policies that have been instituted. Really, sociologists argue that social attitudes and institutional practices still often fall short of true inclusion. Have you ever heard the crawl on Washington? If you haven't heard of that before, in the 20th century, in the mid 20th century, to advocate for the Americans with Disabilities Act, folks with disabilities actually went to Washington and crawled on the Capitol steps because there was a lack of accommodations even in the quote unquote the People's House, which is the Capitol in Washington, D.C. So there was a really powerful protest that helped to spur this act. Again, the role of advocacy here. And then universal design and accessibility. So advocates here argue really for universal design, which means that we should be designing spaces and products that are inherently accessible to all people, regardless of ability. And this approach really aims to remove barriers before they even arise, right? So this promotes a more inclusive society where disability does not equate to disadvantage. That's what I want you to take from this, is that when we think of disability advocacy, we think of that universal design component. It's not about fixing a problem after it occurs or fixing an accessibility issue after we discover it. It's that we need to be more holistic, more preemptive, and understanding that we should be designing things that are accessible from day one, not 2 years down the road when we have to fix that accessibility issue. Again, where disability does not equate to disadvantage. And number 6 here, disability culture and identity. Disability as a positive identity. So many quote unquote disabled individuals, many individuals living with disabilities and advocates reject the notion that disability is solely a deficit or a lack, for example, and instead these folks embrace it as a unique identity, as a part of our unique identity and cultural experience. So disability culture really celebrates the resilience and creativity and community of disabled people, emphasizing that they should not be viewed solely through the lens of pity or inspiration and looking at just this sort of spectrum. And empowerment and advocacy is a strong component here, that disability rights movements have really pushed for a shift in how disability is understood, emphasizing nothing about us without us. So trying to promote self-determination and autonomy and voice within policy and cultural discussion. So what do we mean by nothing about us without us? That if you're writing a policy about folks with disabilities, whether even if that's supportive policy, you have to include the voices and the perspectives of those folks, whether that's a policy or community initiative, whatever it might be. And so this type of advocacy work has led to much greater visibility and with a redefinition of disability as more of a social identity and greater accessibility laws. Again, we have a long way to go in this area, but advocacy, there's been a large benefit and movement around advocacy that has really done a really great job of pushing us in the right direction, still with a long way to go. Again, some sociological perspectives on disability, similar like I did with mental health. We're just looking at the type of sociological theoretical concepts here. So let's talk about symbolic interactionism. So this perspective really focuses on how society's symbols and interactions shape our understanding of what is disability and our understanding of it, how it operates. And so labels and language play a really significant role in how disability is perceived in social interactions that can either reinforce stigma or even promote inclusion, right? We talked about labeling theory. That's an important part of symbolic interactionism. So symbolic interactionists study how disabled individuals navigate social expectations and how they define their own identity in relation to societal views. Structural functionalism views society as a system of interrelated parts and analyzes how disability might, quote unquote, disrupt social stability or require adaptive changes. So, for example, functionalists here might look at the role of caregiving or social welfare and public health initiatives in supporting people with disabilities and their inclusion within the social structure. And then conflict theory. So this perspective emphasizes power dynamics, viewing disability as another dimension where inequality and oppression occur, persist, and are exacerbated. So conflict theorists critique how capitalism values productivity and independence, marginalizing largely those who do not conform to those standards. And this theory addresses issues like exploitation, lack of access to resources, how social policies often reflect economic priorities over true inclusivity. I mean, there's issues on many both sides of the aisle on this as well. So I actually recently heard this concept, heard the disability conversation, this topic come up in a discussion of abortion rights in the United States. And there's two people talking, and you hear this actually quite a bit, where an argument of when does life begin, essentially. And one person said in promoting abortion rights for women in society, that life begins when it is self-sustaining. So essentially after birth, when a child can maybe not function because they need to be fed and everything, but can survive on their own. And then the critique here of this argument is that, well, how would you define life as self-sustaining? Say for an individual with a disability who requires a wheelchair, or who requires a sort of breathing support apparatus or some sort of life-supporting technology or support system, is that person not then feasibly alive? Well, of course they are. So there are constant critiques around the discussions of even in other conversations that marginalize people with disabilities and the experience of people with disabilities. We have to understand the really interesting concepts here and important concepts in our approaches to people with disabilities. So really just lastly here, the last couple of things, policy implications and the sociological approach to disability. So from a sociological standpoint, addressing disability requires more than medical interventions. It involves reshaping societal attitudes and increasing accessibility and enacting policies that promote equity. So sociologists advocate for inclusive policies that consider these social aspects of disability, such as equitable education, employment opportunities, and accessible public spaces. And really, sociologists here argue for creating environments that are accommodating to all people, recognizing that disability is often a societal issue rather than solely a personal one. So in summary here, the sociology of disability, like I've mentioned, emphasizes the experience of disability and is deeply influenced by societal structures, cultural attitudes, systematic barriers. And rather than viewing it as an individual issue to, say, overcome or to fix, sociology calls for a societal shift towards accessibility and inclusion and a respect for diversity as an identity, as a unique identity with unique experiences that we should seek out to understand better. And really positioning disability as just that, as an identity rather than just a personal limitation. So really just the last couple of things here, the overlap between mental illness and disability. A couple of key topics here is just that stigma and marginalization are associated with both mental illness and disability, often in the same breath. And I also want to consider how mental illness and disability are both medicalized, yet subject to social biases. And then also think about the importance of distinguishing between physical disability, mental illness, and chronic illness while recognizing those interconnections. So oftentimes these conversations around physical disability, mental illness, and chronic illness, these things often get looped together. But there is intersecting dynamics here. It's also to understand the distinctions as well as interconnectedness. So be thinking about how can society better support individuals with mental illness and disability to achieve greater social inclusion and equality? How can you as potential policymakers and leaders in the world and healthcare providers and social providers, social work providers, how can you all take these perspectives into your day-to-day work? And then finally, just a couple of conclusion and takeaways, just to, again, kind of just a recap of the main points here of the session of the sociology of mental illness and the sociology of disability. So number one, Mental illness and disability are shaped by societal norms, expectations, and structural factors. The sick role can create dependency, but also social isolation, especially for long-term conditions. And we critiqued the sick role, right? We critiqued the limitations there and the issues around it in these areas. And then third, that there is a need for policy reforms that really recognize mental illness and disability as complex, socially constructed phenomena that require social as well as medical support. Just as a final reflection question that I want you all to be thinking about, maybe include in your discussion prompt, how can a sociological perspective on mental illness and disability, like we've talked about throughout today, how can that change our approach to healthcare and to education and employment policy? So be thinking about that applied factor here, about how this perspective can better how we deliver healthcare and include people in society. And then just one more reminder that your second paper is due Sunday, April 6th, by the end of the day. Please let me know of any questions you have about anything we've covered today. Happy to meet one-on-one as always. And please let me know of any questions you have about the second paper coming up. Please read through that. And again, just let me know. Thanks for tuning in today, everybody, and we will see you next session.